pain is one of the most common conditions that people suffer from and seek healthcare for. It is more common than cancer, diabetes, heart disease combined. A lot of conditions end up in pain. I'm a pain management physician. My name is Belamkar. I go by Dr. B or Dr. Vinay. I've been practicing pain management for the last 10 years. I'm currently at the Apollo Pain Center that I started last August. We have two offices, one in Indianapolis at the Pyramids on the 8th floor in the second building, and I also go to Frankfurt one day a week. So I'll talk briefly about some of the common pain syndromes. And one of the common ones that limit people and has a lot of impact on patient well-being and functional capacity and things people can do is what we call lumbar spinal stenosis. Next slide. Next slide. So as a pain management specialist, I am trained to evaluate and treat all different kinds of pain. Pain that is sudden or long-lasting, such as low back pain, which is a common one, sciatica, neck pain, shoulder pain, multiple joints pain. So the goal of pain management, unlike most common perception, is not to just get rid of the pain, but to improve quality of life. And sometimes we're successful at both, like we're going to discuss with lumbar spinal stenosis. Sometimes we can do our best to improve the quality of life, which is vital. Quality of life means you want to be able to do things that you'd like to do, like do your job well, take care of your family, go to your ball game, enjoy your kids, things like that. So my training background, a long time back, I was an internist, then I went into anesthesia, and then as a pain management physician, we're trained to do all kinds of procedures, all the way from simple injections to complex invasive procedures that work on the spine and elsewhere. So we can actually relieve pain more and more rather than just say, hey, here's an injection, we got it better for a few days, or here's a pain pill that will help you for a little bit, but then you get dependent on it or tolerant to it and doesn't work as well. So I think as a pain management physician, I'm very excited that we have more and more things we can offer that actually fix pain, relieve suffering, improve functional ability, and the risks are much, much lower than the traditional things we used to do, like surgeries, injections, medications, things like that. Next slide. So going to a specific condition called the lumbar spinal stenosis, it's a story. It's a pattern of pain. It's not a MRI. Of course, we use MRIs and X-rays to diagnose things, but what it is listening to your story, listening to your pain story is what I call it. So one of the common stories is people say, hey, I used to be able to walk all over the mall. I used to be able to go do things. I used to be able to cook in my kitchen, work in my garage, but now I can't. I find myself leaning forward. I have to go sit somewhere every few minutes. So it's a very slow onset of what we call insidious. It just creeps up on you and people just kind of adapt to it little by little, rather than, it doesn't happen overnight. So you can't say, hey, January I was doing this, February this happened. A lot of times people say, hey, you're slowed down a lot, or somebody else says you are leaning over a lot, you're not walking upright, you sit down too much, you're getting, I use my air quotes, lazy, which is not the case. People want to do things, but they can't. And that is a slow, gradual process that people just adapt to. And so you have to recall, when was the last time I did everything I wanted to? And it's usually a few years, and you notice slowly your function has gone down little by little. And most people are told, hey, you're just getting old. We're all going to get old, but the pain and suffering should not be to the point where you can't do basic, common things like take care of yourself or enjoy your life. Next slide. So the common approach is, and we all start this way, and that's the right thing to do, is the simplest thing, the the least risky, such as physical therapy. Maybe your muscle imbalance, there's weakness, and we can work on that. Then we go to epidural steroid injections, things like that. And the story with that is most people say, hey, do the same injection you did first time because it worked great. It's not working the same way. You probably did a different injection. And it's the same exact injection. We put in the same medications in the same place. The problem is your stenosis, or the mechanical issue, has gotten worse and it doesn't respond as well. So it is frustrating. People say, oh, the first injection you did lasts 6 months. Now it barely lasts a month. Of course, everybody tries pain medications because they do work in some people, but the problem is after a while, your body gets used to it and it doesn't work as well. Then there are more advanced things like spinal cord stimulation, which are kind of pacemaker wires that go into your spine, sit on the epidural space, just like an epidural you would get for surgery or having a baby. But instead of using drugs through little tubes, tiny holes, we use electrical impulses to kind of change how your spine responds. And that's a great option, but it is not solving the problem. It is basically changing how your spine transmits pain and works to some extent, but after a while, we are not changing the problem that's causing the issue. And we'll talk about why that is and how that works. The other issue is you have spinal fusion. There are multiple reasons where you really need this fusion. So fusion basically means exactly what it says. They're going to join the parts of the spine. The spine moves nice and flexible. As we get older, the issues come up. And one of the treatments is to fuse the spine segments so they don't move, which works great at that segment. But now your movement has to happen at the next segment, and it takes up more stress that is not designed to. There are things like radiofrequency ablation because there's arthritis in the little joints in the back, and burning the nerve, what we call, it's not actually burning the nerve, but it stuns the nerve and they stop working for a while. And it seems to help back pain. But again, it's not solving the problem. And your leg weakness, your ability to walk, stand, and do things you want to do are very limited. Next slide, please. So as we age, we use our spine, where the wear and tear sets in, and the spine starts to constrict. Most commonly, we see it over age 60. 14 million is an estimate. I'm sure there are more people because we just tolerate it. We don't complain about it. And it's the commonest reason to have spinal surgery in the Medicare population over 65 years old. And when we say spinal surgery, it's the incision, opening up your muscles, breaking up the bone. And it works great. I mean, you're decompressing it, but it is a pretty decent surgery. It's not heart surgery, but it is pretty invasive. And there's not a medication or a pill you can give to reverse this. You heard about cholesterol pills reversing atherosclerosis or heart disease, reversing diabetes by diet, exercise, losing weight, things like that. But this is something, once it's happened, the mechanical problem, it's not going to melt away. Next slide, please. So I'm not going to get into too many nitty-gritty details, but the human beings are the only animals that walk upright, perfectly upright. There are other animals that kind of hop on 2 feet, but most of them do not carry their whole body weight on their spine and their hips and their legs. So the spine was designed one way, and then we stretched it out and made it upright. So we have much more curvatures in your spine compared to any other animal. And most animals have the spine horizontal for the most part. And it puts a lot of stress in the lumbosacral, that is the joint, the tailbone and the lower spine, lumbar spine or the low back. And that's where human beings tend to have the biggest issues with low back pain. So basically, if you think about the spine, it has two contradictory functions. One, it has to protect your spine, which is very important, is as important as your brain and the nervous system. And the second function, unlike the skull, it has to move and it has to let the nerves leave the spine. So it's trying to do two things at the same time, and over time, something has to give. And usually it is the nerves that start getting pushed around. Next slide, please. So if you, on the left side of the picture, the healthy spine, we are cut it through one of the lumbar spines, and it's a healthy spine. The front of your belly is at where the healthy is, the word healthy. The back is where the pointy thing is, and your right and left on each side. So we're going through a disc space, and you can see those wires going down the canal, and they're nice and well distributed. They're sitting in there, they're floating around. And as the nerves leave, there's enough space for them to breathe, and they're not kinked or pressurized when their spine moves through the normal range of motion. When it's tenosed on the right side, then the canal gets squished. And the first thing that happens is the blood flow to the spinal nerves, and the canal gets affected depending on what position you're in. And that is very important, why your symptoms change when you're sitting, standing, walking. On the right side is a side view. So your belly is pretty much to the left of the screen on this side, and the back is this side. So the nerves are leaving through the canal, and a great description I heard is like when your socks lose their elasticity and it falls down, they get crunchy and they get bulged, and those bulges start pushing out on the outside structures. Unfortunately, behind those discs are the nerves and the other ligaments that are pushing back. So next slide. So what is Vertiflex procedure? It's called the interspinous spacer device. Fancy way of saying, if you look on the right side, we are between the two spines. If you look at the back of a dinosaur, there's the spine sitting out. So they look like that inside your body, and they're connected to the vertebral bodies. So when you stand, those spines come together and everything scrunches, and the spine in the back gets squished. And the blood flow, it's like putting a little rubber band on your finger. It turns blue, starts getting tingly and numb and funny. When you take it out, it gets better. So every time you stand up, it squishes, cuts out the blood flow, squeezes the nerves, they don't get oxygen, and it feels like a leg is turning to jello. Or your back feels like it's unstable or achy, and you have to sit down. It's not a conscious thing you can fight. It's like anything else. Your spine basically taps out, your nerves basically tap out, and you have to sit down. So by putting the spacer device, we don't let that happen when you stand up. It stays open just like it's sitting, you're sitting, and the blood flow keeps going. And all you need is a little drop in pressure. If you look at the math, if somebody's interested in the physics, even a little opening of the space drops the pressure by the fourth power or something like that. So the key is to reduce the pressure on the blood vessels, keep the blood flowing, and the nerves happy. Next slide. So this is a cartoon animation of how it seemed to work, how it is done. And the key thing I want you to focus on is that incision is about that size to introduce that instrument. And the device goes well above where we even put the epidural. So the chances of infection, bleeding, causing trauma, you must have heard of CSF leak or the spinal fluid leak, is almost impossible to do. I will never say never in medicine. Everybody has a weird anatomy once in a while, but it is in a space that is not exposed or related closely to the sensitive structures or the delicate nerves and the membranes around the nerves. So it's a very safe procedure. It's done as an outpatient. It hurts as much as, say, epidural. A lot of times we can give you some sedation or some anesthesia, just depending on the situation. And it's the 20 to 40-minute procedure, depending on 1 or 2 levels, and you go home the same day. I usually give a binder just to remind people not to bend, twist, move, and then over time, as that 2 tines of the butterfly heal in and it gets scarred in, is not going to move. So from a safety standpoint, in my opinion, it is more safer than even an epidural. Epidural goes actually next to the delicate membranes around the nerves. This is even 1 step away from it. We're just putting a spacer way out there so the whole spine doesn't collapse when you stand and walk or in certain positions. Next slide, please. This is a good example of an MRI. Normal MRI would be the dark stuff in the middle surrounded by the white stuff. The white is actually water. Spinal fluid and any water shows up as white on this particular MRI image. The nervous tissue, the spinal column, the nerves coming out of it is dark. So you can see the white fluid on the top is surrounded completely. So it's like a cylinder with the nerves hanging in there, well distributed. But as you come down in the lumbar spine, the scrunched up SOX effect comes in. The SOX has collapsed and the disc is pushing out, and the poor nerves are the ones that take the brunt. There's no white stuff there because that's water. It's pushed out. Any pressure, the water goes away from high pressure to a low pressure. So you see this garland-like approach. And when you put the spacer device, we open up enough, now you can see spinal fluid both in the front and back for the most part. So that tells me that if the water can flow around the nerves, the blood is flowing around the nerves. And remember, these MRIs are done when you're lying down flat. It's not done when you're standing. So obviously, if you could do a good standing MRI, it would show worse changes than what you see when you're horizontal lying and there's no pressure on your spine. Next slide, please. So a common question is, how long am I down for? Sometimes we put a couple staples. Sometimes, most of the time I use glue or subcuticular stitches that absorb themselves, so there's no stitches to take out. We ask you not to do anything strenuous for 4 to 6 weeks. 6 weeks is even better. So once that heals up, it doesn't move. We want to give it a chance to heal. The incisions, we heal up within a few days. So you should be able to shower. I ask people not to soak in a tub or get in a swimming pool for maybe 3 or 4 weeks. Walking is good. And a lot of people expect, the response is interesting. Some people get good results right away. They start noticing the next day, yeah, I'm able to stand longer, walk longer. Other people, it takes a little bit longer for those nerves to relax. You know, they've been irritated, they've been squeezed for years, and they've been going through this squeezing, unsqueezing cycles multiple times for years. So it takes a few weeks for the nerves to heal. But usually by 4 to 6 weeks, a lot of people notice a significant relief. And most commonly, people say, I didn't even realize that I finished my shopping when I went to the grocery store, things like that. But the first week or two, I wanted to take it easy, then slightly increased activity, no lifting more than 10 pounds. That's a gallon of milk type weight. No bending, twisting, so you don't torque the spine too much. But that's a short-term limitation for a long-term gain. And the incision, you can barely see it, about the size of a dime. Next slide. So we have been doing this procedure for a while now. I did my first procedure, I think it was 2017. And there have been multiple studies and reports of improvement. And basically, we are trying to get you back on your feet so you can take care of yourself, do the things you enjoy. So if you talk to people who had the procedure, 9 out of 10 are satisfied. 85% reduce their use of opioids, which is great. Physical function improves in 80%. And these are general questions. These are not like, is your back better, is your leg better? How is your physical function? So a lot of people have other issues like have shoulder pain, knee pain. So they still may not get back to 100%, but if you specifically ask them about their back, legs, that was limiting them, that's probably is much higher. The leg pain symptoms, 75% of the time is a lot better. And this is 5 years out, some of the studies. So they're not like 1 week, 1 month. And if you look at a lot of the opioid studies, they do it for 3 months and they say, hey, there's no risk long-term, things like that. So these are real. The reason is simple. These things take a long time to develop. So once you release the pressure for anything like that to happen, it takes a long time for it to build up again. And this metal device is not going anywhere. So it has long-term results, which is the other good thing. We're not doing something that'll give you a few months of relief and you're back to square one. Next field. So, we, as a pain management doctor, one of the exciting things is it gets lost in all this noise we hear about problems with the healthcare, the insurance, who's going to pay for it, it's expensive, the hospitals are doing this, the doctors are doing that, the scientists are saying something. We lose the vision of what we can do today for pain management is mind-boggling. The things we can do to actually fix pain, take away side effects, not have to depend on opioids. I rarely met a patient who said, I'll take opioids no matter what. They're there for pain relief, and we're doing more and more things for pain relief. So one powerful technology is called neuromodulation. I'll take a step back, and basically there are two ways to treat pain. One is to fix the problem, like if you can fix the lumbar spinal stenosis in some way. If you have if you have a broken bone, you want to heal it. If you have an appendicitis, you want to take care of that, and the pain usually goes away. The next best is change how your body perceives pain. So whether you take Tylenol, Motrin, Lyrica, all the other Cymbalta, all the other medications, and all the pain medications, they're working on the spinal cord, the brain, the nerves, to change how they conduct electricity. So they want to make the pain impulses lesser and non-pain impulses stronger. And that's what we're doing chemically. So we decided, this has been going on for 30 years and we're getting better every year. So we put a little electrode around the nerves and turn it on. It's like a symphony, the electrical activity. And if anybody has done the high school experiment or kindergarten, the experiment in school, where you run electricity to the wire and you put the iron filings and they line up, it's very similar. That field gets projected on the spinal cord, the nerves, and it changes. So basically we're doing with electricity at the point where it is targeted, where it needs to be, whereas when you take a pill, no matter what it is, it goes all over from your head to your toe, to your liver, to your gut, and you have all these issues. So Tylenol can cause liver problems, non-steroids can cause gastritis, heart disease, bleeding. Opioids can cause their own rash of problems. So this is a great way to target pain relief. And it's not spine surgery. It's placed as a needle in a wire. And we make an incision to bury the pacemaker, just like you put a pacemaker for your heart, things like that. So this technology has really evolved in the last 5-6 years. For a long time, they were kind of doing okay, 50% pain relief in 50% of people was kind of what we were saying, But this technology has really taken a leap forward. And these days, we can do a lot more. Next slide, please. And of course, we're not limited to pain from the spine. And the spine itself is a complex organ. It's not just one thing. So you can have pain from the disc, pain from the nerves, pain from the joints in the back, disc-related issues. So we evaluate the pain rather than saying we'll look for this condition or that condition for which I can do a procedure or injection or surgery. These days I can say, bring me your pain, we'll have some solution. So it could be knees, it could be shoulders, it could be a neck, abdominal pain. So no matter what it is, there are different, and the key is to start at the least invasive, least risky, and escalate it. At some point you may need surgery, but it's getting less and less necessary as, and even then when you need the surgery, you may not need the whole 9 yards. Maybe you need surgery for 1 or 2 parts, and the other parts you deal with things like stimulation, radiofrequency ablation, peripheral nerve stimulation, dorsal ganglion. One common disease that people we overlook a lot is called CRPS. So basically, when your foot or your arms, usually knees, after some kind of trauma or surgery, sometimes you don't even recall what the injury is. You see color changes, temperature changes, spasms, the foot feels hot, cold. That's starting, I start thinking about CRPS. And it used to be a nightmare disease and we had no solutions, but now it's flipped the script and we can actually fix those. Neuropathy, diabetes is a common. Some people have it for no reason. Some people have it because they had medications, say for chemotherapy for cancer, some other medications, some infections. So things we can do has just spread, and I'm excited and very optimistic about the future of pain management and what we can do for people, and makes me get up and go to work every day and be excited about it. No matter all the noise in the background about all the problems in healthcare, and we have many, but from a pure technical medical standpoint, I think we are at a place where we never were, and it's exciting. Sorry about the phone. I think that, next slide. So if you have any questions about the particular procedure, most of the procedures we do, including the lumbar spinous, is an outpatient procedure. You go home, it's covered by most insurances. We make sure they're approved and all that before we get you through that. It's a metal, but it doesn't, it's like, it's much more less amount of metal than say a knee or hip. So it's not going to set off the airport security, things like that. So if there are any questions, I'll be happy to answer that. If not, enjoy the sunshine and time to get back to joy. So again, my contact information, if anybody's interested in being evaluated, see if something we can do to improve your pain and relieve your suffering and relieve your dependence on medications and things like that. Please feel free to call me or have your doctor refer you. Happy to take care of you. Thanks.